Awesome. So the recording is starting. And just before we start, Kelly, just quick announcements for people listening at home. We do have our pelvic pain masterclass in Chicago. 19 people registered so far. We're almost full. So if you want hands-on practice, go check that course out. It's in September. And we also have in California 2 courses in October and one in Vancouver. They're all CEU approved. So if you're looking to have hands-on experience with real life models, go check that course out. And if you have any questions, you can message us. So today we have the chance of having Kelly with us, who shared a very interesting case because from what I understand, you've been working very hard with that patient. It's been but there's still like pain with urination at the top of the penis. Is that right, Kelly?
Yes, that's right. Um, do you want me just to kind of give the background?
Yeah. So what we're gonna do, Kelly, is if you can give a quick, background on what you did so far, and then we're gonna dive into the 10 questions. And
Okay.
like usual, we're gonna do just questions for the next 10 minutes. So anybody that is here with us, please do ask the questions that you have in your mind, and then Kelly will be able to provide more details. So no suggestions of any kind. Let's just, questions to really understand the case, because it's the first time that we meet this patient through, Kelly. So let's make sure we really have this holistic picture before we start, you know, giving suggestions, so everything is coherent. How does that sound? Awesome. So yeah, Kelly, can you just give us a quick, 30 seconds, 1 minute rundown of the case? So who's that patient and what you worked on so far, maybe some of the challenges that you're seeing right now in clinic, whether that's from the patient side or whether that's your internal thoughts. It's always good to share that. I mean, we're a very niche specialty, so it's always good to hear what's on your mind. So, Kelly.
Great. Yes. And thank you all for being here to help provide some insight onto this patient. Um, this is a 23-year-old male, and I started treating him around the end of May. He contacted my office with complaints of pain with urination, about a 1 year history. And so he had been to urology, all the things checked out, no issues from a urological standpoint. They did diagnose him with IC, or chronic bladder pain at the time. His symptoms were pain with urination, urinary urgency frequency, perineal pain, rectal pain with bowel movements, and penile pain. Um, gradually just kind of got worse and worse instead of better. And I think maybe his mom was like searching what to do and found pelvic floor physical therapy. So they contacted me, when on his evaluation, he did say that the bladder pain did increase somewhat and became more intense when he felt like his bladder was filling. It was difficult to try to hold back urine. He had urgency. When he had to go, he just had to go. He had pain with getting an erection and then post ejaculation. Also, being on his feet with his job increased his symptoms. He also complained of difficulty or hesitancy starting his urine stream. He would have to push to void. He complained of a weak urine stream as well. Some burning. With coughing or sneezing. He had sharp pain in the perineum. He did not have constipation, but he did report pain with a bowel movement and difficulty going, but on the Bristol stool scale was a 5 or 6. He did report no pain with intercourse per se, but with ejaculation, he complained of pulling sensation at the testicles. His sleep was very poor. He would get up to go to the bathroom 2 times a night, and he was having nightmares. I would say other subjectively, which that I felt like was important, at the time, sort of around when this all started, there was a lot of stress. He had moved out on his own for the first time from his parents' house, in an apartment with some roommates that he did not get along with. He had a boss that was just, in his words, like a jerk. And he was, doing some pretty manual labor, like lifting heavy things in a warehouse at the time. Since then, he left that job and got a desk job. So that was, it's been a while since has had that kind of manual labor job. He does play on a men's baseball league 2 days a week. Objectively, nothing cervical, thoracic that was, stood out. He did have decreased range of motion with left side bending in lumbar area. His hip, he had increased pain with internal rotation bilaterally of his hips. Kind of a slumped posture, a tall, lanky kind of guy, thin, little forehead, head, rounded shoulders, does a lot of video games, kind of slumped, sitting when he does that and watches TV. Those things I noted as well. And let's see, a shallow breather. I noted that, a positive slump test. Let's see, other objective findings. Yeah, tender to palpation and overactivity with internal pelvic floor muscle assessment. He had tenderness to palpation at the perineum and the ischiorectal fossa greater on the left. And his pain he was rated his pain at 9 out of 10 on evaluation. So that's kind of that in a nutshell. So I've been seeing him for almost 3 months. He comes in weekly. Some things that we have, done, just some central nervous system, like down training, diaphragmatic breathing, pelvic floor muscle stretches, internal work, abdominal, like myofascial release, some visceral mobs of the bladder. And I even, I did some paraspinal, like lumbar, thoracolumbar paraspinal mobilizations, kind of around the thoracolumbar junction too, in addition to lower lumbar area, adductor myofascial release. I did some inguinal, like femoral nerve kind of, I don't know. I really didn't know what I was doing, to be honest, but I was trying to like mobilize like around the inguinal canal because he did have some sensitivity there and his lower abdominal area. And I did like spermatic cord release. Trying to think. And then here lately, I've added back in some strengthening because his symptoms have gotten, he's just improved gradually over these 3 months. He does not have any urinary symptoms anymore as far as urgency, frequency, or pain. And he doesn't really complain of perineal pain with coughing or sneezing anymore, but his complaint now is he describes it as a warm discomfort with urination. And that, he kind of rates his, you know, pain at about a 2 or a 3, with uh, with urination. So that's his biggest complaint now. And yeah, I'm just not sure where to go, how to get that last, like, maybe 20% for him.
Mhm. Thanks a lot for sharing the case, Kelly. And you
Sure.
obviously seem to care a lot about the patient, and that's awesome. You're trying all different kinds of treatment, and you've explored many different kind of treatments, and you've been able to get that 80%, but there's still that 20% that is left. So, thanks for sticking with the patient, because I know it's not easy, especially when it seems that that patient has a lot going on. And as clinicians, we can compartmentalize all we want, but it does affect us when patients come with this kind of emotional, um, more charged, subjective history. So that's great. So now I'm gonna pull up the 10 questions, and if we can just quickly go through all of them. And if you're new to this case discussion, we go through the 10 questions not because they're just like random questions. There's actually a lot we can get quickly from those 10 questions. So if you don't know why we're asking that specific question, do not hesitate to ask in the chat, and we'll explain the rationale behind each of the question. But so far, let's go through the 10 questions, and then we'll open it to the clinicians who are on this call today, and we can ask a couple more questions just to make sure that we get this holistic picture. And then we'll start, based on that, just start brainstorming about, okay, what could we try next, and we'll go from there. Okay, so let me just share the screen. Awesome. So just a thumbs up if you see the 10 questions. Do you see the 10 questions? Awesome. So Kelly, I know you already jotted down the answers to the 10 questions. So if you could just go, 1 to 10, maybe just in a minute, boom, let's get through those 10 questions.
Sure. Okay. So number one, about the pain with traumatic injury or surgical intervention. No, there was no traumatic injury or surgery. The second one, the pain is located in the perineum, the abdomen, the inguinal canal, and the tip of the penis. And it has not changed locations. It's kind of stayed throughout. Number three, no paresthesias. Number four, yes, he has urgency, frequency, pain with urination, pain with bowel movements, but not constipated, pain after ejaculation, and when urinating. Five is, I couldn't really ascertain if there was a correlation necessarily with sitting, standing, or lying down. I felt like it was more with slumped sitting when he was playing video games, or maybe in his office chair. So we did talk about his seating situation at work. Number six, yes, the pain is consistently with urination and bowel movements and after intercourse. Also at the perineum with coughing and sneezing. Number seven, it's just pain after ejaculation. And eight, I did not ask that question, and that's a good one. I should have, but I didn't ask if there was a difference between the two. Number nine, not positional there. And number 10, yes, there was just that mild back pain with his job in the warehouse. He said he felt like he kind of maybe heard it at one time, but he didn't really, it did not prohibit him functionally.
Awesome. Thanks for going through the 10 questions. Woody, if you don't mind, because Kelly, you said it's, number seven's a good question that you're maybe gonna ask your patient. But Woody, why is number seven a key question that we're asking? Can you just refresh our memory? Woody, you're muted.
Yeah. Okay. Sorry for that. Yeah. It's number seven. It's number eight.
8.
It's
Oh, it's
eight,
eight.
right?
Okay, eight.
Yes.
Yeah,
Yeah.
eight.
Yeah.
My
I think
mistake.
it's very important question to ask. And I actually have today I have one patient. I see him, and I think he has pain in the urethra. And one of the things he described, his pain will get worse during masturbation, but when he have sexual intercourse, and there's just no pain at all. So we do see some, people coming in with pain during sex, and when we further ask a question, they're gonna tell you the difference between the two. I think because you know mechanically and psychosocially, they're all different. So for example, sexual intercourse, there will be a lot of movement in the spine, but the masturbation, men tend to stay in one position, right? It's like a static position. And, sexual intercourse also involved, probably sometime higher stress level, because if they have pain and, they want to perform, but in masturbation, they have more control. So they tend to be, slow down. They don't have to go that fast. So I think it's a very useful question to ask. And this case today, when I see it, and he has pain while in the clinic, and by changing position, and immediately there is because he slouched and there's a pain. So after I change his position, the pain just almost disappeared. So that's a good understanding why masturbation, the static position, actually can cause a lot of pain. Yeah, I don't know if that's clear.
Yeah, thanks for sharing that, Woody. And I just want to reiterate on what you said, because I think that's a golden nugget that we can all easily use in clinic. It's like, okay, let's put the person in static position, maybe more slump, and then see, is there any change of symptoms? Because if that's the case, then we get a good indicator very fast of, okay, maybe there's something worth exploring there, and it takes literally maybe like 30 seconds, and it's not too complicated for people to test it out. So definitely, I think that's great. Thanks for sharing that, Woody. So now let's open it up for questions for clinicians who are on this call. So if yep, the floor is open, so you can type it in the chat or directly open your mic and go ahead and ask Kelly some questions. We're going to use the next 5-6 minutes or so to do that before we do a more detailed analysis after we get a better sense of the case.
Kelly, was curious because I know you said his main chief complaint is the warm kind of feeling, 2, 3 out of 10 pain that he has with urination. Is he still having pain with sexual intercourse? I don't remember if you mentioned that.
His only that's gotten a
Or
lot better.
post-ejaculation, yeah.
Yeah. So it is just what he's now describing it as is not really, it's after ejaculation when he goes to the restroom. So it's, I think, seemingly more related to, I don't know, the urination. I'm just not sure. Yeah, that's where I'm stuck. And then any repeated overpressure or sustained pressure to the thoracolumbar junction, and what type of spinal mobilizations did you do? So I did just like some PA mobs. I did some QL stretching. Then I started doing let's see, what else did I do? I don't think I did, really overpressure. That's probably a good thing. Repeated overpressure, did not do that. But that's a good thing, I think. So would you do like for the repeated overpressure, would you recommend like active or passive with that or both? Or would you kind of thinking like prone press up or just standing extension?
That's a great question, Kelly. Please hold that thought because we're gonna respect just questions right now, and then after that we'll dive into maybe why Nick and Patrick asked those specific questions, and if you guys can
Okay.
detail as to why you're thinking that's an important detail, please share your thoughts because we're all trying to see what's your rationale, clinical rationale, because we can all learn from that. So that'd be great. I think there's another question from Rachel. So she said, hi, is the urination pain at the start and of urination? And then does the pain tailor off immediately or hang on for a while post void?
It is at the start, and then of it kind of tailors off. It doesn't really hang around.
Okay, awesome. And Patrick's asking as well, any sacral restrictions or work done?
I didn't note any sacral restrictions or do any work in that area. So no.
Okay. And then Rachel's asking, also wondering whether voiding positions differing, such as sitting or standing, makes a difference.
Oh, I didn't ask that. I guess I just assumed he was standing, but I think it's probably wise to ask. That's a good point. I did not discern between those two.
Yeah. And that's totally fine, Kelly, because we have such limited time with our patients, and there's just so many questions we can ask, and there's already a lot of information. But definitely, I want to dive afterwards into why clinicians thinks these questions are important, because I think understanding the why and giving us this kind of framework to work around will be very useful for all of us to understand. Okay, Woody is saying, I wonder if all the pain present is present at the same time.
No. No. So if all of his different pain complaints, they are sort of at different times. So he has just the tip of the penis pain with urination. And then like with cough, sneeze, that only happens, or the perineal pain really only happens with that. So I think they're different.
Okay. Okay. That's very good to know. And then Patrick is asking, any OI tenderness? I'm not familiar with this acronym. What is
Obturator
OI?
internus.
Oh, okay. Obliterator internus. Okay. Yeah.
Yes.
Yes.
Yes, he did have tenderness with that and um limitation in the range of motion there. And we did work on that.
Is he still tender on obturator internus?
It is less, trying to think, I saw him on Tuesday. It is less, he's less tender there. Than he was for sure. And he does have a little bit more range of motion. But he is particularly on the right hand side. Yes.
On the right hand side. Okay. All right. So one more minute for questions before we move on to maybe more the analysis of based on what we know from the case. So any other questions that people have right now? Patrick's asking, any foot injuries?
No foot injuries. Yeah, he doesn't have any other significant musculoskeletal or medical history. His Yeah, no foot injuries.
And then Pranjali is asking, how is the hip mobility?
Um, he is, I would say, nothing, I would consider it within normal limits, but he is tight in his hips. He can get into a deep squat. He can, get in, has full range of motion, but it's not easy for him to get there.
Okay. All right. So a lot of information to unpack. And of course, when there's so many information and so many things to explore, we do need to select what are our priorities. So I'd like to ask, people who are here, what would you look at next? And let's dive into the why. I think there's a couple of clinicians right now are saying, at least from what I can assume from the questions, it seems that clinicians are interested in the spine. So let's go with Nick first. Nick, why the spine?
Um, I would say because it sounds like maybe there was some pelvic floor tightness and that kind of stuff, but that's cleared up. But with it being just the tip of the penis, it tells me that there's probably more nerve involvement, especially because Kelly, you mentioned that there was a little bit of nerve tenderness that you tried to nerve glide out as well. But then also with the high pressure abdominal stuff, you said that sometimes that will cause pain too, which leads me to think that maybe there's also that extra pressure towards the spinous system and the nervous system through the spine. And then just because, sorry, my dog just saw a car. And then on top of that, an area that you haven't really delved as much into, especially with your patient being slumped over more often and probably not getting into that extension based spine motion like you should. That would be my next area to really look at.
Thanks for sharing.
Yeah.
And I think Patrick also resonate with some of that by his question. What type of spinal mobilizations did you do? Am I wrong, Patrick, or is there more to it as well that you want to add?
Right. So whenever I'm, one of the first things I think of when it's the tip of the penis pain is the distribution from the spinal nerves from the sacrum S2 to S4. That's the distribution. So, and it's also pudendal nerve involvement. So that always kind of sends back and through there. So this is my first time here. I'm a manually based therapist. I do a lot of manual work. I also do visceral mobilization. I also do craniosacral, all that kind of stuff. So I always look at this as one of those sort of the mechanics sort of thing about how am I going to make the machine work better. And so the things that I feel like, is to look at is one is the OI tenderness, since that's really, the side of Alcock's canal, and that's gonna get the pudendal nerve. That's just, to me, that's a big driver that's still gonna irritate, especially if he's pushing really hard when he's urinating. But that's exactly where that's gonna send it. And if you have the restrictions in the hip, that's gonna do that also. Same thing with the sacrum. So even though you sort of look at the sacrum and it's not, I think everybody thinks of the sacrum differently, and depending on how much manual stuff that you've done and joint mobilization and everything, the sacrum can move symmetrically, yet still be tight. It's still kind of wedged in there a little bit into the pelvis. So a lot of times something simple, well, that's why I'll do it, right? We're going to do things later. OI tightness, sacral. That was it. Yeah, those were the two things. I always kind of go after. I always put it as like, how is the sacrum working? And how is OI anything that's going to be affecting a pudendal nerve? The other thing was like SS and ST, sacrospinous and sacrotuberous ligaments, how they anchor right in through there, and they're going to be on either side of Alcock's canal. Sometimes those can be caught up in all of this too. So if the sacrum's not moving, you got to find out. It would be like, I'd want to know, is there any tenderness in those ligaments going down into there? Because that can also affect Alcock's canal, affecting pudendal nerve. That was my note.
Okay. Yeah, that's
Yeah.
great.
Sorry, that's a
Thank
lot
you.
of stuff.
That's good. That's great. Can
So-
at some point could you like share like what kind of
Yes,
modes you do? Okay, cool.
but he
Thank
said
you.
later, so I'm trying to follow
Yeah.
the rules.
Thank
Yeah.
you.
Awesome. Appreciate that, Patrick. Thanks for sharing your thoughts. And it seems that clinicians so far, we agree that there's some sort of nerve involvement and you know, of that sort, and that could be a driver of the pain. Now I want to ask Woody, because Woody, you explained to me this kind of master switch kind of analogy, and I think that's a great one. So can you share the master switch analogy, because I think it could fall very well within this case.
Yeah, I think if you allow me, I'm probably gonna share a case, and this case I think probably quite similar to Kelly's case, and we can probably from this case we can see if there anything we can apply to to her case. Is okay? Can you just
Yeah,
read
I
it
just
right?
gave you the right to share. So okay,
Okay.
cool. So we're getting a case within a case. So it's like Inception type
Okay.
stuff.
Yeah, I
Awesome.
think this case. Let me share this. Okay, so this is the. Let me know. I cannot see my. Let's see. Can you see this case? Everyone can see? Oh yeah, okay, good. Okay.
We can see it. Yes.
So I think even the pain location is quite similar. This is a case is a patient from the States, and I see this patient through telerehabilitation. So because when I see this patient, if I cannot do manual therapy, I have to figure out what I can help this patient. So this patient is 46 years old, and if I just pull out the pain location, I think it's quite similar. He has this tip pain, and he has a growing pain on the left side, and also the perineal pain towards to the left side. And then there was pain also going down to the leg. Okay, so why I mark all this pain? Because I asked Kelly about the question if all the pain present at the same time. So when the pain, they change location. From my perspective, there's a highly involvement from the central nervous system, probably from the spine. So this patient, he has this story for almost 3.5. And if you look at what make the pain worse, actually, sitting make it worse, leg cross make it worse, and during the sectional course, slightly better with standing and lying. This is just he treated by 2 pelvic floor physiotherapists, and they tried even 2 pudendal nerve blocks, and just there's no benefit. And this is a letter actually the therapist shared, and I think it's very useful. And one of the sentences she said, she did a treatment to the tibial nerve, and which is there is some changes of the symptoms. So she thinks there is probably a higher involvement of the spinal nerve. So that's really inspired me. And because I have to, track the pain and figure out what can be the problem. And then I started asking a patient to document how the pain change location. So my priority is to rule out the spine as the primary driver. So that's my initial plan, because if the spinal is the driver, that's the master switch I mentioned, because all this nerve, they're highly involved, concentrate in the spinal level, while when you move the spine, they have a rapid influence in the spinal function, which is sometimes can turn off the pain immediately. So that's in my initial plan. And this patient also have a restriction to left side range of motion of the spinal, So this is the first week I gave his extension, repeated extension of the spine. And what's happened is the pain doesn't change. And you can see the pain is always 4 or 5, 4 or 5. And he did exercise 3 times a day, nothing changed. And then the second time, I say, yes, let's see if his pain is more on the left side. What if I just angle the spine, just to push the hip slightly off center to the right side, how that's going to change. And what's happened is, if we see, probably going to just, I don't know if you can make it bigger.
You'd have to go into full presentation mode, but you can maybe just describe it. I think, yeah, I'm not a Windows user, so.
Okay, so what happened here, if you can see the pain increase, when the hip off center, the pain start from going down to 7. And another thing is, if you remember the pain chart, the number 3 pain is correlate the tip of the penis. He said after he did this exercise, there is way more pain in the tip of the penis. So I think if we treat the spine, if we have a back pain, sometimes the pain radiates to the leg, we know there's this centralization phenomenon. So we know when the pain moves from proximal to the distal, that's not a bad sign. That's not a good sign. So he had a lot of pain in the tip of the penis. So then we switch to the plane, only do the side gliding to the right. And because what's happened, because he said in the past he has this back pain, and there's a therapist treat his back, give this exercise, and seems help his back. So we just started doing the same exercise, and then what's happened? He said this is the best week he has, and then eventually, all this pain in the pelvic pain just disappeared, and he only present the pain in the lower back. So this is if you think about centralization phenomenon, we have multiple pain in the peripheral, and while we correct, the spinal component, and the pain just all of a sudden centralized. So this patient at the end just have no pain in the perineum, no pain in the tip of the penis, and there's only pain, minimal pain around the 3/10 of the lower back. So this is the case. And I think when we treat multiple pain locations, we have to probably sometime figure out which pain, if we can change, gonna indicate there is a better progression. So I think in this case, when the tip of the penis, that pain disappeared, I'm pretty confident, and this is a good way to go.
Mm-hmm. Yeah, thanks for sharing this case, Woody. And I just want to point out that's interesting because it's kind of like the Pareto's law. And for people who don't know, Pareto's law is like, okay, that 20% that will affect the 80%. So if we're just, we have all these symptoms and there's a lot of things we can work on, more peripherally and go one by one. But then if there's one thing that we can focus on first that does this big change, I think patients are just more motivated in general. And it seems that a couple of clinicians here at least pointed out towards the spine, whether it's using a more manual based approach and focusing with manual therapy on the spine, or whether that's an exercise based approach. I think as long as the right junction is targeted at the right intensity, we get the same effects. And the other thing I want to point out is really to track the symptoms, because you described so many symptoms, Kelly, and I don't remember any of them, to be honest. Like there's so much. I think we just need to focus on the main ones, the main complaint, and check which one we can compare in clinic, and which one is realistic to test, retest, because I think that's an indicator to see if what we're doing is driving in the right direction. So Woody, do you propose like the log, like to track that, or what do you use usually? Because the
I
case you
definitely
shared.
think, Kelly, if I would suggest you use the pain log and then really give different exercise and try to see document, in terms of when he do the exercise, how that's impact on the pain location. I think that's very good information to use, to find the right way to progress exercise.
So, what sort of, with your patient in the case that you presented, what exercises, because the two cases do seem very similar to me too. What can you kind of describe some of those that you did?
Yeah, I think if think about his posture, he tend to slouch, and I mean, well, if you told me that there is a restriction to the left side, and also when the patient cough or sneeze, I think in terms of which part of the spine I would go after, probably, the lower thoracic spine and upper lumbar, probably a good place to go. And I think just think about our daily activities. We tend to be more in the flexion pose. I think extension is always a good point to start. But before you do the extension, probably it's good to have a baseline. For example, like I mentioned today, the case, I intentionally let the patient to slouch and just let the pain in the perineum start to accumulate, because I know, well, that is a patient have a pain, that can be a good baseline for me to track when I, play around with the spine. So this patient, when change the posture from slouching position to upright position, there is immediate relief of the pain, from the pain, let's say from 6 all the way down to 2. So that means when you change the spinal posture, and there's influence on the pain. So that's giving me quite confidence, probably I need to rule out the spine. So normally extension is a good point to start. So if you can lie the patient on their tummy and, do some like repeated extension, the key is really get to the end range, get to the end range of extension, do a couple of like repetition. Normally I do, 1 set or 2 sets of 10, and I will get patient back to the initial position and to check the baseline to see if there's any changes. If there is, for example, change of the pain location, for example, if the patient pain from the tip of the penis move back to the anus, that's a centralizing phenomenon. That's a good indicator you have to go. And if the pain decrease by 30%, if they say, oh, I think 30% is better, that's a good indication, probably you have to keep moving for the spine. And also, check the mechanical response. For example, if there's tenderness to a certain area, you can use as a baseline, do some repeated movement testing, and get back to check the tenderness. Or you can use coughing or sneezing as a baseline. For example, ask a patient to cough, if it can produce the pain, the warmness, the hot, all the sensation, and then get patient repeated extension or other movement, get back cough again to see if there's any modifications of the baseline. So if you get the 2 or 3 changes in the clinic, that's a good indication, move on, probably going to get a very positive result.
Yeah. And thanks for sharing that, Woody. And yeah, I want to point. Oh, I'm just gonna maybe mute the TO. Yeah, thanks for sharing that, Woody. And it's more tricky, of course, when it's like tele-rehab, because that patient, you couldn't have this kind of manual assessment, so that makes it trickier. And it's great to see that the exercise you prescribe is great. I want to point out that the fact that, combining it sometimes with like manual assessments as well, that can help pinpoint the spot, because sometimes when just doing like extensions like that, and it's not the right junction, like there's no change, like Woody, when you said like there's no change, but when you do like PAs, maybe like unilaterally, and check for the segment of that specific spine, which Patrick seemed to be doing, and then really target that specific junction, that's where you might get the best effect. So it's not just like, oh, let's move the spine. It's sometimes it's trickier, and you gotta find the kind of right angle, whether that's through the exercise or whether that's through the PAs. So it gets a little more tricky than that. But I think that the Northern Star that guides us, it's really, okay, does it change the symptoms? Like, can we get some baselines that are changed? So if there's two, three baselines that you find that are reliable, that provokes, discomfort or pain that he can do in clinic, and then quickly do your thing and then check right after. Okay, did that change? I think with that, it's more it gives you more feedback, because otherwise we're just moving a bit in the dark and we're trying things and see what stick and what doesn't. But if we go with this approach, at least like he can also see that whether it's moving in the right direction or we need to change, and give you more feedback for that. Okay, so we have only 10 minutes left. We have any other comments? And I mean, Kelly, also, if you have questions, please do ask. If any clinicians want to chime in and give their thoughts as well, that'd be appreciated. We're all here to learn. There's no stupid questions or stupid comments. It's a safe zone. We're just here to learn. So if you have anything, please
I just want to
don't
say
hesitate.
it was really cool. It's really neat because even though we have like different perspectives, like you said, Zen, like a manual therapy assessment or doing like repeated movements, it's really neat that we all came to the same position. So we all kind of identified that this is most likely some sort of neural involvement. And Mickey said, hey, oh, sorry, Woody said, hey, let's start up at the spine. Like Pat saying, hey, let's look at the different canals or different placements. And then for Kelly, it's like, okay, now systematically going through, okay, I'm going to start at one spot, rule that out completely, and working your way down or working your way up or wherever you want to start with. Now you have a nice structure. And we all kind of agreed on that. It's really cool. It's just neat. So that's awesome.
Thanks for your comment, Steven. I mean, all roads lead to Rome, right? So that's a different approach, but we're all thinking the same thing, more nerve assessment. So let's go in more detail. Let's fish out to see if there's anything that can be worked on. Let's be more specific about the baselines and see, can we affect the baselines based on that? Because otherwise, I mean, so many symptoms. I feel like especially for me, when I started, like, so many symptoms, I just feel like a headless chicken trying to run around and throw things and see what sticks, and it's not a comfortable position to be in. And add to that, like, the stress of the patient and that emotional charge, it's a lot. But if we can simplify our practice and really target, okay, what's that 20% that will change to 80%? I think that's a good rule of thumb. We feel less stressed, patients more confident, we're more confident, and I think everybody wins, because at the end of the day, we just want to help, right?
I agree.
Okay.
I think the way you say is, we all have our own toolboxes. Mine happens to be manual. There's some people who do more exercise.
Patrick, it cut off, so I don't know if yeah. I don't hear you. Is it just me? Now you're muted, Patrick. Yeah, now you're
Now I'm
unmuted.
okay.
Awesome.
So
Yes.
apparently I'm not a tech guy either. So we all have our own toolboxes. And so, like you said, what we're doing, so I tend to do things manually, but I've worked with people who do things. PRI is a real kind of thought process for movement and all that. And so you can fix sacral problems through exercise. You can be very specific. It's just you have to be comfortable with the tools that you use. If you want to get into specific examples, I mean, I kind of try to like to do both. So if ever I'm doing something with sacrum and I want to get the sacral moving, I'll tend to have the patient, because I'll do the sacral stuff, but I want it to hold as they're going on. So I'll have them do vertical foam roll lying. So you lie long ways on the foam roll. So the sacrum is getting a mobilization from the foam roll, and the anonyments are being pulled down by gravity. So you're getting sort of an SI sort of mobilization just from lying there. Knees are bent, feet are on the floor, so that you don't increase the anterior tilt and the extension of the low back. I saw this comment somewhere in the chat too. It's like, oh, I see this all the time with the people who play the video games. So posture is that whole thing. And anytime you're talking about the sacrum, when you're talking about this spinal involvement with that, just looking at the posture, are they anterior tilted, are they posterior tilted, and then fix that or work with that the way you know how to do that, get those neutral mechanics. And so whether you're doing it with exercise or with manual stuff, because I can't teach you my manual stuff right now, but it's if you kind of look at it that way, as long as you can fix that and get those going into more neutral or more symmetrical, that's probably going to take the stress off of the system, right? And right now, something's stressing the system, something's stressing some nerve somewhere apparently, and that's what we want to do. My other suggestion, since I'm talking, with the OIs, which I always feel is a big driver, if you're doing the release of the OI. So if you're going to go in there, like if you're doing internal manual release, you can always pair internal manual release with a passive range of motion of the hip. Because if he's still real restricted like that turned in, you might want to get that little bit of extra that's going on in there, because if you're on OI, you're also going to be on sacrospinaeus, part of pudendal, right, part of Alcock's canal, blah, 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 all that kind of stuff like that. So I tend to find a lot of direct internal manual, both with men and with women, but with a passive in through the hip, because you can sort of find where the restriction is and where the trigger point is, and then you can hold and you can do either indirect or you can do the stretch or something like that. So I tend to find that takes a lot of, you get a lot of good results in that when you're trying to get those hip restrictions in there. So those would be my suggestions.
Thanks for sharing your techniques, Patrick. And
Thank you.
it's great to see the approaches and the different kind of approaches. We only have 5 minutes left. You know, time passes very quickly when we're having fun. Claudia has her hand raised. So Claudia, do you want to chime in?
Thank you. I was just gonna add a little bit into, since everybody is giving here a little bit of tips of what they use. So it's very nice to hear that Patrick has the visceral and the cranial. I also have some background in those osteopathic techniques. They are absolutely important for pelvic health, but one that we can do super easy. I love the book, is the DNM by Diane Jacobs. So I do that one as well. Whenever we pick up that the driver is central, like Woody said. So, and then I will work on that pathway of the pudendal nerve, or, you know, if it's going to be the lateral cutaneous, femoral lateral cutaneous on the thighs, right? So all those areas. And Diane's book has a pelvic chapter, and it's very simple technique. It's very simple. So the whole idea is to work with the cutaneous innervation to actually, from the cutaneous innervation, activate deeper nerves, the nerves that we can't really reach, right? So it's a different way to think of nerve flossing. And the cool thing is that, so I work actually more with women, and this is a beautiful technique for pregnancy, because I'm more careful about needling pregnancy. And as soon as I do DNM, is dermal neuromodulation, as you guys know, that pain is gone, right? Even if it's on the SI joint, which is that classic one, or we're dealing with the sacrum. So I'm at the back, and then one hand is at the sacrum, one hand is at the thigh, and you actually kind of stretch that nerve path, the nerve bundle, and the pain goes away. So it's a very cool technique.
That's awesome. Thanks for sharing, Claudia. And we love those quick wins when there's rapid changes. And I think when it's spinal involvement, we have this kind of master switch, and we can just like switch it off with like either techniques, manual techniques, or specific exercises that targeted the whatever, you know, can turn off the switch. And that's the fun part to figure out in clinic. Okay, 2 more minutes, and we have one question, because I think Rachel also is asking. Woody, could spine be the source of slow urine flow from your experience?
Yes, I think definitely. You know, we always think about the pain as a baseline. But actually in the clinic, anyone coming in without pain, just with any urinary symptoms, can definitely, come up with from like spinal origin. So this has really come from like when I was practice surgery. So when I have a lot of patient, back when I in the orthopedic department, sometimes when patient coming in the emergency, and they start to say, oh, you know what, I pee slightly difficult. And one other thing we have always rule out if there is any, cauda equina. So that's really, we have a high alert. And one other thing I noticed, a lot of patients that come in, even they present with, some sort of cauda equina symptoms, but 80% of them that, radiographic negative, they present all the symptoms, but there's nothing changed in their cauda equina. So when I came to Canada, I have this path, I switched to physiotherapy. So, and that's the first population I pay attention. And actually, I think in 2017, I published my first case series and to describe 3 men with only changes of urinary functions without pain, but actually rapid change when we start working on the spine. So one of the case actually been diagnosed with chronic cauda equina syndrome. And this guy have really like kind of like urinary retention symptoms. He has difficulty to empty the bladder fully. And then when we manage the spine, within 2 or 3 sessions, he was easily empty the bladder, and even confirmed by the urodynamic testing. And it seems everything just he empties so well. So in 2013, there is this Italian clinician, I think her name is Siracosa, published a brief review document about 40% people with spinal discal herniation and actually have abnormal urodynamic testing. And this is even without they complain any symptoms. So the short answer is yes. Definitely all these urinary complaints, put them as a baseline, monitor them rather than target one symptoms at a time. So if we put everything together, it's just way more making sense. And think about the spine as the master switch. You can turn off not only just a pain, but you can turn off the urinary symptoms, defecation issues just rapidly if you really figure out.
Yeah, and it's already 10:01, so we'll wrap it up. Thanks for sharing your thoughts on that, Woody. And also, I think one thing that marked me very much is when you mentioned that example. We'll not go into detail, but that example where there's like autonomic changes also with the skin color, and think that was that's super also interesting to see that the spine or the nerves can lead to all these kind of different symptoms. And I think Ricardo, you asked the question, which baseline would you use in the clinic? And I mean, it's a great question, but I don't think we can answer that fully now. And just to give you maybe the quick ideas is really, 2-3 things that are meaningful, painful or restricted in terms of movements, whether that's at the spine, whether that's like urinary symptoms or any other kind of pelvic symptoms. So there's a lot that you could potentially use. And in our masterclass, we go over it in 2 hours, so we won't be able to do so here today. But if you attend our next case discussions, we'll mention other baselines as well. I think it's really case by case to be able to find the best baselines. So thanks everyone for being here with us today. And Kelly, thanks for joining us. It was such an interesting case, and many clinicians shares their thoughts. Thanks, Patrick, Claudia, and everybody else who chimed in. It was super interesting to hear the perspective of everyone. So hopefully that helps, and it will be recorded. So we'll send the recording for review. So yes, if you find new stuff by using some of the techniques shared by clinicians here, please do send us an email. We're always happy to hear from you and see that it helps with your practice and helps your patients get better results. All right. So have a great evening, everyone. Bye.